Good morning, everyone. So just regarding my talk, I'm also just talking a lot about monitoring response during neoadjuvant chemotherapy as well. Thank you. And so just establishing neoadjuvant chemotherapy, what it is. It's chemotherapy obviously given prior to surgery. And primary endocrine therapy is when hormone-blocking drugs, for example, tamoxifen, are given prior to surgery. The purpose of neoadjuvant chemotherapy is to shrink cancers prior to excision. This increases surgical options, most importantly allowing breast-conserving surgery instead of mastectomy, and it also enables the oncologist to assess response to treatment and, if necessary, change treatment in a non-responder. What are the reasons why we should be imaging and monitoring patients undergoing neoadjuvant chemotherapy? If the cancer is not showing a good response to treatment, a change in chemotherapy regimen may be necessary. If there has been a good response, but then there's stability or progression, a biopsy may be warranted. In the case of a stable lesion, biopsy can show whether there remains viable cancer as opposed to fibrous tissue. This may influence whether additional chemo is necessary or to proceed to surgery. In the cases of progression radiologically, biopsy can indicate whether there's been a change in biology. Maybe a more representative sample shows a different tumor biology, which assists in choosing an alternative chemo regimen. So what do we use to guide us in determining what is a tumor's response to neoadjuvant chemotherapy? We currently don't have any clinically based protocols or guidelines. We do have access to the REES criteria, which states as follows. So CR refers to a complete response where there's a disappearance of all lesions and pathologic lymph nodes. Pathological response refers to a greater than or equal 30% decrease in the sum of lung diameters of lesions, that there are no new lesions and no progression of non-target lesions. SD is stable disease, so hence there's been no progressive disease, nor has there been a pathological response. And PD refers to progressive disease when there's been a greater than or equal to 20% increase in the sum of lung diameters compared to the smallest SLD from the baseline study, or progression of non-target lesions or new lesions. Oops, sorry. Two different terminologies. When we refer to a complete radiological response, we are implying there is no visible tumor on imaging. Obviously, a complete pathological response is something that the pathologists can only ultimately decide at the time of excision that there's no residual malignancy left on pathology. So what are the different methods of monitoring response when a patient is undergoing neoadjuvant chemotherapy? There is clinical, which is palpation, which the oncologists and surgeons will be employing. And then for radiologists, it's ultrasound and MRI. Oh, sorry, my little icons. Okay. So ultrasound for monitoring NAC is great. It's non-invasive, it's quick. We can do serial ultrasounds to measure the largest mass. Ideally, we should be using the same radiologist because it improves reproducibility and accuracy. And what do we measure? We measure the maximum diameter according to the REES criteria, or volume. So the question for radiologists is, what is more accurate, maximum diameter or volume? The REES guidelines for solid organ cancers entails measuring the maximum diameter of up to 5 lesions. In a breast unit where I used to work previously, we did quite a lot of research and we prefer to measure volume based on 3 measurements. So width, length, and height. 2 measurements with the probe in a radial orientation and 1 with the probe in an anterior radial position. The reason for this being is that masses don't always shrink concentrically. A mass that flattens would have the same maximum diameter but a smaller volume. We measure the volume of the two largest masses in a breast and the diameter of the largest axillary lymph node. You can also measure the thickness of the lymph node cortex. So here we go. This is on ultrasound, the probe in a radial and anti-radial position, two measurements at 90 degrees from one another. Here's just an example of a patient that we followed up with volume. There's the baseline study in April. Sorry, the measurements are really, really tiny. We'll come back to that now. But we're using the longest diameter and then calculation of volume measurements over a period of from April to July. And as you can see on this table, the volume initially was 8. The patient had a marked initial response with a reduction in about 70% of volume, but then unfortunately seemed to start progressing again with that measurement in July, and the chemotherapy regimen had to be altered. This is another patient with a large cancer at the time of diagnosis. After 2 cycles of chemotherapy, you can see there's a marked reduction in volume going from 12.9 to 0.38 moles. Okay, just the same measurements. So tabulating measurements, calculating a volume seems to be really accurate, which the oncologists like, and gives a more fair reflection if that mass is not shrinking concentrically. Right. Monitoring image response is also really important for primary endocrine therapy. As you can see, whoopsie. We've got a mammogram on the right-hand side. This patient has got a cancer in the inferior aspect of the left breast. There is a marker in situ. There's the cancer over there. Patient demonstrated a fantastic response to primary endocrine. Here we've got our longest diameter and calculated volume of our baseline mass. Then post at 3 months, we're reassessing, and there has been a marked response. Here's another patient on primary endocrine therapy with markers in situ, mass not visible at 1 year. Right. So then coming on to MRI for monitoring neoadjuvant chemotherapy, it's the most accurate. It's got the high sensitivity. It's got a moderately high specificity. And MRI's accuracy is due to the fact that it demonstrates biological viability of cancer, mainly through post-contrast enhancement. Diffusion-weighted imaging also indicates viability related to tumor biology. MRI can identify whether a residual mass contains a viable cancer, and it's the first choice for diffuse disease, which shows a cancer, be it invasive disease or DCIS. So it shows cancer extent with a high degree of accuracy. What's also really important is involvement of the skin, nipple, and chest wall. And MRI is used when ultrasound is equivocal or there are confounding factors such as fat necrosis, which may mimic a recurrence or malignancy. MRI can really be done early after commencing neoadjuvant chemotherapy, even after the first or second cycle. And it really is most useful when we're monitoring patients during and after neoadjuvant if a baseline was performed. All patients undergoing neoadjuvant chemotherapy should have pre-treatment MRI scans. They can also be used late in treatment to assess for non-response or progression. They unfortunately can't be used if a mag seed was placed due to the extensive artifact. And occasionally, MRIs can underestimate disease due to overall reduction in contrast enhancement caused by the taxanes. So, monitoring response on MRI, what would we be using? Once again, the REAST or volume measurement. Most MRI software can calculate the volume of an enhancing viable tumor. And what we look at is the degree of enhancement. So the proportion of cancer which is showing rapid initial enhancement and washout on delayed phases. So once again, some cancers shrink concentrically. They are easiest to assess. Some cancers, however, disintegrate, and they can be a little bit harder to measure. Here we go. Sorry. Oh, there, the slide's not superimposed. It's just on my side. So here we've got a patient who had extensive disease in the right breast at the time of diagnosis. After 4 cycles of neoadjuvant chemotherapy, has had an almost complete pathological response with marked resolution, and that mass has gone. This is a patient who is very interesting and was followed up from July to October. And the areas that we're discussing are really important in terms of what MRI can demonstrate. So extent, enhancement, and lymph nodes. So you can see this patient was diagnosed in July, had a baseline scan. There's marked rapid initial enhancement with washout, indicative of invasive disease. Patient's got pathological lymph nodes, unequivocally involved. Unfortunately, this patient developed progression on treatment, as you can see by September's scan. Chemotherapy was amended and then went on to have a much better response after that second cycle. So when we're talking about MRI, for me the most important, and I think the most accurate, is volume and degree of enhancement. So as I said, most MRI softwares are able to calculate volume, which, as you can see, our program can, and then we use those to measure on follow-up scans. And then degree of enhancement, so initially your baseline scan will show marked enhancement depending on tumor type, and follow-up scans. Lack of enhancement will tell us that that cancer is demonstrating a good response. As the first scan, you can see there's avid enhancement. The second scan, it's more persistent. It's demonstrating that there is a response to chemotherapy. And although there might be viable tumor left, certainly this patient is responding. Something just to touch on, which is really important with patients undergoing neoadjuvant chemotherapy, is the importance of biopsy markers. So biopsy markers are essential before neoadjuvant chemotherapy commences. Tumors are very difficult to visualize on ultrasound sometimes post-chemotherapy due to complex breast tissue, be it fibrocystic change, masses, fat necrosis, or scarring. And because these tumors often become less hypoechoic and more indistinct as part of a response to chemotherapy, these areas need to be marked prior to commencing chemotherapy. Markers also help identify the cancers. Markers are obviously very important in the event of a complete radiological response. Cancers that are no longer visible cannot be localized by the surgeon. This reduces the ability to perform breast-conserving surgery. The pathologist also needs to determine a complete pathological response, and a marker helps identify that tumor site. So as we can see on this mammogram, there's markers in situ. Those are the sites of the cancers, and this patient has had a complete radiological response. But those markers are in situ for the surgeon and pathologist later on. This is just a patient for Y localization, which we don't really do much of anymore, but same, complete radiological response, but markers are in situ. This is a patient which unfortunately didn't have a marker and has had a complete radiological response. There's no visible tumor and there's no marker, which places the surgeon in a predicament, as well as the pathologist, in terms of having to have a look at that breast post-op. This is a patient with an almost 4 centimeter triple negative cancer that was treated with neoadjuvant. You can see on mammogram there in the upper outer quadrant and occupying actually most of that left breast. There's the size of the tumor. This is also the same patient, had a complete radiological response. MRI demonstrated, unfortunately, no markers to depict the tumor site. And lastly, this just shows the extensive artifact of MagSeed on MRI. So just to be aware that those, if you are going to be putting in MagSeeds before the time, and a patient might need monitoring during the course of their neoadjuvant chemotherapy, it does produce extensive artifact. I think the scout markers are compatible with MRI, so that's less of an issue. And that's it. Thank you so much for having me. In conclusion, I think that there are no current clinical criteria to establish guidelines for us monitoring response during neoadjuvant chemotherapy, but it is the radiologist's responsibility to help surgeons and to help determine surgical excision by determining anatomical extent before chemotherapy and then imaging response after chemotherapy. MRI still remains the best modality for evaluation of that.
Thanks, Luke. Any questions? Nothing. I've got some questions. What about, so you haven't mentioned mammography at all. Just, you've shown us some pictures, but I mean, you said, your main modalities is clinical, ultrasound and MRI. You don't think mammogram is a good thing to use?
So mammograms, for me, I don't use just because if there are calcifications, they can't be, if the calcifications remain, it's not exactly a representation that there's residual tumor, or it could be residual tumor, it could be DCIS, it could be necrosis, it could be fibrosis. So response on mammogram for me, I mean, maybe for your bigger masses, absolutely, if you don't have access to a quick ultrasound, but I don't use it, no.
And contrast-enhanced mammography?
So that's at the forefront now. It's very exciting. It's the current studies are showing that it is comparable to breast MRI. It's still investigational. We're currently using MRI before contrast-enhanced mammography, but I think the studies, the last ACR one that I read, it is going to be comparable in terms of efficacy when compared to MRI.
Okay. Because the way I understand it also, that contrast-enhanced mammography is really, it's easier. I don't know whether it's cheaper than MRI.
It's much cheaper than MRI.
Cheaper.
Yeah,
because that's the biggest problem is, I don't know, I don't work in the private sector, but I mean, we've got very limited access to the MRI scanner at Fortescue. And it's expensive. So I don't know what the medical aids will pay. Multiple MRI scans is going to be very, very expensive. So, I mean, I don't know I don't know who's using it. Etienne, maybe you've got some comments. Are you using MRIs? What are you guys using in your unit?
Yeah, thanks. So yes, we do, but limited. So I think that's the first thing is it's selected patients. It's usually some patients where the tumor is very ill-defined to start off with. It's difficult to sort of gauge the response to therapy. Or tumors that have unusual biology and you're not sure if the selection of neoadjuvant therapy is appropriate for those patients. But I must say that there is a very significant non-correlation between the histology in the end and the imaging, even with MRI. Not as much if you have a very clear, nice sort of picture, but you often have, especially the young women, have lots of sort of background non-mass enhancement. You have lots of other changes in the breast that does sort of make it difficult. Frequently, the initial MRI is done post-biopsy, so that changes things a little bit. So we use it, but we use it in a very specific, limited situation. If we need to make a decision whether the patient's a non-responder and we need to change the therapy that we're planning to use.
I think that's probably the answer, is to use it selectively and pick your patients clearly.
The medical aids generally cover that if we need that. I think, so maybe from my side, the one thing that I think the markers are critical, and the biggest frustration is there are many of the units, well, especially in the northern suburbs patients that I drain, that routinely with every biopsy they'll put a marker in. So that means it's there. Never mind if it's cancer or not, because we can always follow up. In a year I can see this is the area that we biopsied before, this is a new lesion, whatever. But there's still lots of the radiology firms, or at least some of their branches, that are not putting in markers. And the problem is now you get the patient, maybe the patient wasn't managed in a sort of centralized team, now you get the patient for surgery and now there's no marker there. So I think that is something, if there's any way we can change that in Cape Town, that there's a protocol that every biopsy should get a marker, that would make a huge difference for a lot of women.
Yeah, and I mean, I think the markers are not that expensive. Just a normal little clip marker, it doesn't cost a lot of money in the greater scheme of things. We spend so much money on these patients that those little clips is nothing in the, at the end of the day, and they are very useful. Just as you talking to someone else. But you guys have got more access to mammography, I guess. I mean, you run a big mammography practice, so I mean, do you use MRI or mostly mammography to follow up these patients?
Number one, we have clinical examination, which quite often is there. Then I'm privileged to work with an excellent oncologist who's sitting accidentally next door to me. So whenever we do neoadjuvant therapy, then we usually get a response. So that we are getting a non-response is exceedingly rare. Ne?
Yeah, less
Yes.
than 5%.
Less than 5%. So, yeah, it's.
I mean, it's pretty.
If you have a look at the histopathology of response, and that's actually very interesting, then you will immediately understand why any imaging method for response measurement falls actually short, because you get anything from fibrosis to neovascularization to hyalinization to necrosis, and that stuffs up imaging no matter which modality.
I think it's also important that when we use neoadjuvant therapy, that you select the modality for the right patient. So if you use endocrine therapy, you suspect a certain time frame and response. And where you use chemotherapy for a very high proliferative tumor, you expect to measure clinically how the response is going. So you've always have to be the only one seeing the patient and have in your head what you expect to see.
Yeah. So I mean, basically, in endocrine, if you put them on hormone treatments, your response is going to be much slower, and you should expect that. The patient's not responding if 2 months down the line. It's not really. They often just soften up on that period. I feel that the tumors are not. They're still there. You can feel them, and they feel big, but they're not as hard as they was in the beginning. They soften up with these endocrine treatment before they really start shrinking down. Obviously, you get some of them that respond rapidly. But overall, they sort of soften up. And I think, where we use MRIs at Groote Schuur, maybe a little bit more, and it probably doesn't fit into this context, but that's the lobular cancers, because they can be very sneaky. Especially if there's a discrepancy between what you feel and what you see on your mammograms, you really need to do an MRI on those patients, especially if you're going to do breast conserving surgery, because they can, what you see on mammogram is a 1 centimeter mass, and you do an MRI and it's 6, 7, 8, 9, 10 centimeters in size. So just be careful with the lobular cancers. There, I think MRI is very useful.